Hi, this is Brian Wormers recording a lecture on the care of patients with brain disorders related to infections for medical surgical nursing at the University of Sioux Falls. Some of our learning objectives would be talking about CNS infections, talking about nursing priorities for those patients with meningitis or encephalitis, talking about collaborative interventions for patients with CNS infections, and talk about some of the prevention of meningitis, especially in those highly populated areas. So meningitis, this is inflammation of the meninges surrounding the brain and spinal cord. It can be viral bacteria, it could be fungal, it could be amoebic. There are a couple of different ways to do this. Viral is probably the most common, followed by bacterial. Viral is most common, but less serious. Bacterial tends to be more serious. But the nice thing about that is we do have medications we can give for that, so antibiotics are more effective. So some of the subjective history, so recent infections, brain or spinal surgery, any upper respiratory infections, headaches, photophobia, phonophobia, so lights, noises, myalgia, nausea, vomiting, headaches, or chills. If they have a rash, this is a specific rash, and this rash is petechia turning into purpura, so the capillaries are bursting. And you're going to get a lot of third spacing with this, and this is usually associated with a Neisseria meningitidis, which unfortunately is on the rise. So if you ever see petechiae turning into purpura and it's a rash and they've got other signs and symptoms of infection, do your BSI, protect yourself, protect your patient, and realize that this could be meningitis. So with this, fever, rash, abnormal eye movements, decreased level of consciousness, nuchorigidity, which is that stiff neck if they try and put their chin to their chest, Kerning sign and Brudzinski sign, so you can click on these two and see what those are like. Kerning's is like moving the knee, so you're at 90 degrees and then you kind of open up that leg a little bit and see if they have a sign with that. Brudzinski's is moving that hip and that knee together and seeing if they counterbalance and try to reposition to alleviate some of the stress. And then of course seizures could be a side effect of this. So nursing priorities with this: risk for altered cerebral perfusion, tissue perfusion, pain, and fluid and electrolyte imbalances. So implementation and practice. So what are we going to do with this? So we're going to look for complications, watch that ICP, see if that goes up or down, look for seizures. Can have secondary SIADH with this. Watch for color and temperature extremities. Unfortunately, they can get septic with this. So with that, we're looking for that petechiae turning into purpura. We can look for splinter hemorrhages, which are those little bruises underneath the fingernails, or big signs of DIC, unfortunately. So we're going to monitor using CTs, labs of like a CBC, electrolyte, CSF, and kind of looking at those things. So CT might show some meningeal swelling and inflammation, generalized throughout that whole skull. CSF fluid might see increase in WBC. A big tip between bacterial and viral is a bacterial might have low glucose because the bacteria is eating it. You might see increased protein for both. And then, of course, on that PCR, you'll do cultures and try and see if you can grow anything out of that CSF fluid. Sodium might be low if they've got SIADH, and you might see the volumes of urine increase or decrease related to that. So what are we going to do? Give antibiotics as prescribed or medications as prescribed. You might do antivirals as well. So if it's a herpes simplex virus, you're going to maybe give acyclovir with this one. Monitor procedure activity and keep that patient safe. Elevate the head of the bed helps take some of the pressure off of the brain and can help with that. Supportive care, giving fluids, pain management, and then of course transmission precautions. And this is generally speaking BSI with mask, gown, gloves. So those people that are at risk should maybe avoid some of the crowded areas. Those on very crowded places are at higher risk for meningitis. So college campuses, especially college dorms, military, especially the barracks, prisons, those places. Patients who have been in close contact with patient with meningitis might be put on medications, or guess what, so if you've been around somebody, especially with Neisseria meningitis, then you might be prophylactically treated with Cipro, rifampin, or ceftriax, depending on your exposure. That's why you wear a good gown, glove, and mask. Encephalitis, this is very similar to meningitis, and you're going to kind of see that, but this is more of the brain tissue and some meninges as well. This is more frequently viral, can be life-threatening, inflammation of the cortex, white matter, and meninges, and you might get some demyelination. So this is more of, I've seen this more as like a West Nile or different situations like that, rickettsia or different situations, tick-borne or mosquito-borne type of situations. Can be amoebic. So there's a couple of new studies are out there, especially those people who are doing nasal washes and aren't using distilled water. So subjective, so report any recent mosquitoes or ticks, fever, nausea, vomiting, nuchal rigidity, phonophobia, photophobia, joint pain, headaches. Those kind of situations might lead into this. Objectively, you might see a high fever, changes in mental status, neurological deficits, so doing your cranial nerves, looking at fatigue, and then signs and symptoms of increased intracranial pressure. So that's going to be phonophobia, photophobia, headaches, nausea, vomiting, decreased level of consciousness. And you might see Cushing's triad, which is going to be a widened pulse pressure, bradycardia, and some irregular respirations. So for assessment, so CSF fluid, like I said, we're doing PCRs, trying to see if we can figure out what the organism is. We'll do EEG to try and detect any seizures. If we're at all concerned that they're having seizures, we'll do a CT and MRI looking for inflammation and swelling. So with this, to detect seizures, it's if we suspect seizures. It's not like we're putting an EEG on waiting for this necessarily. Planning and implementation, so acyclovir, especially if we're considering that it's herpes simplex virus, which is fairly common. If it's arbovirus or encephalitis, then there's less that we can do for that one. But once again, try and watch for increased intracranial pressure and keep them safe as possible. So patient education, so try and protect themselves from mosquitoes or ticks. Limiting time outdoors, dusk to dawn, protective clothing, DEET, careful around standing water, and repair the screens of their houses, try and keep the mosquitoes out. Provide patient and family support during this time, and then of course discharge planning. Depending on how severe it is and their side effects, they might need a long-term care placement. So it just kind of depends on how they're doing. That concludes this lecture. If you have any questions, please feel free to contact me.